was in medical school, heart disease was considered a problem for men, and no one ever discussed women except perhaps with rheumatic fever, where women had mitral stenosis. But the rest of heart disease was totally ignored. And what we've seen over time, worldwide, but what we've seen specifically here for us at Emory, is that we have come to recognize that the female heart is vulnerable to heart disease, and that women differ substantially from their male peers in the causes, in the prevention, in the diagnosis, in the treatment, and in the outcome, which says that research is so important because this is a path that is not yet well-traveled. I'm trying to see if I remember the words correctly, but it's something of Emerson, and Emerson said, do not take the path well-traveled, but go where there is no path and leave a trail. And this is what has been the story of women and heart disease, where some of us have left the trail and then people have followed and made this a huge information highway. So this has really been something that we are living. We're living the expansion of interests in women, learning about women and heart disease, teaching women in the community, as well as teaching our co-professionals, and realizing that this is a substantial segment. Half of the patients that are seen in a cardiology practice are women.
That's right.
And we have to realize that there are many features that are very specific to women.
As you know, I'm very interested in the effects of mental stress and heart disease, specifically in women. Thankfully, you know, we have, at Emory, we have a long tradition of studying this phenomenon of mental stress and heart disease. We are at pretty exciting times because if we could figure out a way to leverage artificial intelligence and, you know, social media, machine learning, all these amazing things that the technology, and being able to use that to transform care. Because when I was, you know, started out with training, we had paper charts, and I remember writing notes, and you would sign off on that. And now we have electronic health record. And the challenges that are associated with it, but it's also a gold mine in terms of data and information. We just have to be able to figure out how to use it.
What you and I have seen in our professional careers is simply that once we began to look at sex-specific issues, the cardiovascular mortality in women plummeted. Previously, the decrease in mortality in this country was only in men. And once we began to address specific issues to women, women did better. And as a matter of fact, about 2014, for the first time, fewer women in this country died every year from cardiovascular disease than men. And as I've said before, we are delighted to be in second place, and we hope to stay there.
That's right. And, you know, that is one of the key things, you know, at the Emory Women's Heart Center, where we really want to keep the patient at the focus, right? So, you know, once we keep that in mind, then all of the three pillars for patient care, research, and mentorship, everybody, I think, is just so engaged and enthusiastic about transforming care for women in this area and beyond, you know.
And now what we're beginning to realize is that women's heart health is not solely a medical issue. There's been so much emphasis on the social determinants of health, and it's very applicable to women. And when we talk about education, we're talking about our patients, we're talking about the community, we're talking about the community organizations, we're talking about public policy and legislation. So it takes a village to take care of women's heart health, and we are learning how to expand that into the community as well.